Once it is live, let me know, then sir will start speaking. I'll be online. 30 seconds gap will be there. మాట్లాడండి వినిపిస్తుంది మీరు మాట్లాడుకోండి.
Hello.
Can sir start speaking? Can you start? Okay.
So, good evening, everybody. It's my honor and pleasure to introduce Dr. Meenakshi Swaminathan, board certified pediatric ophthalmologist. She's for us, she's a teacher of teachers because she has taught Dr. Kaushik, our President Medical Administration, during his Pediatric Ophthalmology Fellowship. She has guided Dr. and mentored Dr. Sairani, who has guided Dr. Mahati, and now who is guiding the fellow. So, madam, a grandmother of teachers. And she was there incidentally when I did my Ratan Tata in Shankar 16 years ago. So it's been a pleasure to have hosted her here, and she has gone through our training programs, and she's had a nice tete-a-tete in the morning with all of you confidentially also. So all your secrets she may give in reformative action, and will definitely certainly take steps to better our program. So she's now with she's a very passionate teacher, and she's now with the Ophthalmology Foundation. So she'll brief us before we go on to our grand rounds, which is our monthly routine. Yeah.
Thank you so much for this very kind introduction, and a very warm good evening to all of you gathered here and all of you who have joined the program. I'm here in Guntur in what is said to be the hottest time of the year. But it has been a very special experience to be here amongst very cool people. So I'm hoping to be a part of this wonderful hospital and training program to enhance their already very good training programs with my little ideas of feedback. So without much ado, I just want to take a few minutes to talk about the Ophthalmology Foundation and the Ophthalmology Foundation Education Consortium. It's a mouthful, OFEC. So let's see what this is actually. So if you look here, the Ophthalmology Foundation's board of directors has some very big names. There's David Pyatt, who's the president, and there's Bruce Spivey. And if you look at the board members, when I see a list like this, I quickly look for Indian names, to be smug about it. And I think there's Dr. Adi Ravindran there, and many other very esteemed ophthalmology colleagues from around the world. So how the Ophthalmology Foundation was born is it was basically a new group that split away from the ICO. The International Council of Ophthalmology has many agendas, of which one was education. So when perhaps their priorities and focus changed, this is what I'm told, the educators moved away to form the Ophthalmology Foundation with the complete focus on making education globally better, making and training better educators, because that is how you secure the future of ophthalmology. You want to have great ophthalmologists in India, you want to have first great residents and fellows, and for that you need to have great teachers. So it is a cascading event. So what do we do in Ophthalmology Foundation? This is their website, ophthalmologyfoundation.org. And you can go and make an account. It's a free account. And I will just walk you through what we have there. So the mission, when it states, says Ophthalmology Foundation supports ophthalmic education internationally in order to improve global eye care and advance scientific ophthalmology by helping ophthalmologists become better teachers. And I know many of you think that you write ICO exams with the hope that you may get a fellowship. Now, the news I have here is all the fellowships have moved to the Ophthalmology Foundation. So in case you're wondering, oh, how am I going to get into this? Well, these fellowships, it's very, very possible. An ICO-like exam is in the pipeline with perhaps half the cost. Okay, which is, so it is more globally acceptable, affordable, if you will. Other than that, if your need to do the fellowship is understood and appreciated, you can apply for the fellowships. And all the information is in the on the website. So as you can see, especially focus on low resource and underserved countries to preserve and restore vision for people worldwide. So we may not come totally under the underserved country, but there are still many underserved pockets, many in India. So definitely these fellowships are something that you can think about to apply to. So these fellowships are called the IOFF, the International Ophthalmology Fellowship Foundation, and they're basically from Germany. But the fellowship can be anywhere. They're just funded from Germany. 3, 6, 12-month fellowships. So the second initiative is education. So what do we do in the education sphere? The goal is to maximize the training ability of ophthalmic educators to enhance the skill of ophthalmologists and improve global eye care. So really let's not go into this too much because it's really not relevant. It talks about the hierarchy. But this is the crux of what I'm going to tell you. So the first is there is an online series which is meant to showcase the teaching skills for ophthalmic educators. What do you need to be an ophthalmic educator? What do you need? You need to know how to design a curriculum for your resident or fellow. You need to know how to teach in a really busy OPD. You have to know somebody comes with very little or poor surgical skills. How are you going to systematically teach them? How are you going to systematically assess them? Assess them not just in the outpatient clinic and in the OR, but you want to know 360-degree, how are they? How are they as team members? How are they to the staff? How are they to the patients? So that's called a 360-degree evaluation. So lots of things like this. How do you teach professionalism and communication to your training? All these things are covered in these modules. I believe there are 21 modules now. Dr. Kaushik has taken part in one of them, where we talked about how to use public speaking skills in education. That was the module. So I encourage all young educators. The hall is filled with young educators. So I was just joking, not even joking, I was serious in saying there's something in the Guntur air. Everybody looks average 10 years younger than they are. So, and you know what Shankara Eye to me. Just if you don't quote me, there was a joke. So, so I encourage you to go and look at these modules. And these modules, it's all free. The module has videos. It has the PDF. It has a small quiz that you take and you get a certificate that you have cleared this module. So it's something that a young educator or a senior postgraduate, a fellow who's thinking about going into education, please check it out. And they don't have to be taken in a particular order. You can just pick and choose what you like and take it. The next things that we do is leaders in education. This program consists of a flipped classroom approach aimed at invited teaching ophthalmologists from specific regions, like we have done a program with Malaysian Ophthalmological Society, women in Chinese Ophthalmology Society teachers, Romania. So like that, there are pockets where there was even an invitation from Ukraine, where they have no teacher training whatsoever. So they have no idea how to assess how do they learn cataract surgery? They make, the total number of cataracts is 10 during their entire 3-year or 4-year course. And the end of it, neither is the trainee sure they know anything, nor is the teacher. Right? So, there are, maybe for you, it may come as a surprise because you're sitting in a very sophisticated hospital with access to everything. Become a surprise, but there are many, many such places in the world where teaching is so suboptimal. So we do programs with such groups. And then if you go to the Ophthalmology Foundation website, you also have many resources for everybody. So how to teach, what to teach with, are there new methods of teaching, are there new methods to assess, so on and so forth. Once you sign up, you also get a monthly newsletter, which keeps you updated on the happenings, the courses coming for teachers, new resources that have come up, you get it in your inbox. Okay? And then, of course, the education sessions that happens in supranational, like we had one in All India Ophthalmology Society, we have one in APAO and so on, AAO, etc. The mentorship program, this is, I am the chairperson of this mentorship subcommittee. So this is again a very fascinating thing. So if you have finished your fellowship, for example, and you have 3 or 4 years into your practice, and then say you're a lady ophthalmologist, you just had your child, you've taken a year's break or a 2-year break, and now you're not sure what you want to do. You don't know whether you should go back to do more surgical training, go to a trust hospital, relearn skill, but you seem to be interested in research. What do I do? How do I become an ophthalmologist who does research? Who do you turn for advice, right? Some of us have mentors you can address, but sometimes we don't have anybody, or the mentor themselves may not have that knowledge. Or you say, you know what, for about 4 or 5 years, I want to go to Australia and work. Is it possible for me to do that? That is where the mentorship program comes in. So you can sign up as either a mentor or a mentee. So what the example I gave you is a mentee. You can also be a mentor. You say, you know what, I've done this for 15 years. I want to help others who are struggling. I want to help young mentees. And so it's a very easily signed, a form very easy to sign up. You go and say, what are you looking for? Or a mentor, you go and say what you can offer. What is your expertise? So you take off all these things I can advise about. And then it's a software that connects the two and says, yes, you've been allotted a mentee. So for instance, I have a mentee from Kenya, I have one from Rwanda, one from Oman, and one from Ethiopia. I have 4 mentees. And 3 are ladies and 1 is a male. All 3 of them struggling with midlife breaks. What do I do? What do I do next? I'm passionate about my work, but I've had a long break. What should I do? That kind of scenarios. You know what I mean? So it's a great program to sign up as a mentee. Very good one to sign up as a mentor. And it's really very easy. You just communicate, have a couple of emails, give them resources, ideas, close the loop and you're done. It's not like you're going to be with them till you retire. Just you close the loop and say, okay, I've purpose achieved. Okay, so that's something to check out. Other than that, we have several subcommittees, CPD, education program, etc., etc. I talked about it. Accreditation also is going to be coming, and a pilot is going on. Shroff in Delhi is one of the pilot centers. So you may wonder, what is the idea of accreditation? I already have national board accreditation. This is an international standard. Are you as good a training program as any international program? You know, a program in Australia, a program in China, a program in Hong Kong. Are you as good as them? So that is where this accreditation comes in. And basically, if you have it's like a JCI. If you have accreditation and say, hey, this is one of the best programs, not just in India, but in the world, then you're likely to attract the best trainees, the top trainees. So that is the idea of accreditation, but that's all in the pipeline. I thank you for your attention and your time, and on behalf of the Ophthalmology Foundation. Thank you.
Thank you, ma'am, for enlightening us. Even we didn't know that such thing existed, and it's a great opportunity for all the newcomers who wants to go ahead with their career. Now we have a grand rounds. This grand rounds, the mastermind is Dr. Mahesh sir. He's our retina chief in Bangalore. The basic concept of this is this is also like a training program for our students to be ready for the future. It will be just like a conference where we have a presenter, a moderator, and a panelist of 3 members. And the discussion goes on about a series of cases or a tough case which they don't have answers or something like that. So we usually have it every month, once in a month, where we have the experts from all the specialties and the things will be discussed. So today we have a case series. It will be, there are 2 cases series actually. The first one, the presenter is Dr. Manju. I welcome her. Then we have 3 panelists. One fellow from Kokomo, who is Dr. T.P. and Dr. Divya Bhargavi, our pediatric fellow, Dr. Shivranjani, our PR fellow. They will be the panelists. Then come ahead and the stage. Panelists can move first. Panelists can the form.
Thank you for the introduction, ma'am. Good evening, one and all. Let's begin with Microspherophakia. Before discussing the cases, let's take a brief brush up on basic sciences, the anatomy, and the embryology that goes behind so that we can understand what's going beneath those cases. The lens is that part of the eye that it starts beginning in the gestational age, but it continues to grow as we age through the life. So in less than 3 months of gestational age, it is vertically ellipsoid. So it is vertically ellipsoid, less than 3 months of gestational age, and the secondary lens fibers are added and the anterior part and the posterior part. That is, there is anterior-posterior growth initially until it becomes spherical. So by the 5th month, that is from 3rd to 8th month, it attains near spherical shape. It is at this stage that if the development gets arrested due to malnourishment or there is a defect in tunica vasculosa lentis, that this spherical shape will persist after the birth, causing the spherical shape of the lens. However, normally the growth continues in this equatorial plane. There will be fibers added in the equatorial or the transverse plane, and that will make it more transversely elliptical. And after birth, the cortical fibers, the secondary lenticular fibers, they keep on getting added up and they make the lens more and more spherical. So these are the diameters. There is a differential growth. The equatorial diameter grows at a faster rate because after birth, there are the increase in the equatorial and transverse lenticular fibers. However, the anterior-posterior growth, the rate is very less. And if that persists, that results into the microspherophakia. And this has been backed up by the MRI imaging that has been taken at various gestational ages. At 13 weeks, it is vertically ellipsoid. And around 14 weeks, that is around 4 to 5 months, that is spherical. And after that, it is transversely elliptical. So this is the anterior lens capsule. There is the insertion of zonules around the equatorial margin. And the function of those zonules is traction. So it is the traction exerted by the zonules that cause increase in this equatorial diameter. And also it restricts further growth in the sagittal plane. So the anterior-posterior diameter, it doesn't grow further or it grows really slow. And the anterior-posterior diameter continues to grow owing to the zonular traction. But if the zonules are weak and slender and they are unable to exert this traction on the equatorial plane, the lens remains spherical, causing microspherophakia. So let's see how this pathophysiology gets converted into symptoms. Yeah. Because of the zonular weakness, as we discussed, there is spherophakia. Because of the weak zonules and instability, there will be phacodonosis and defective accommodation. It can subluxate anteriorly or posteriorly, And owing to the spherical shape of the lens, we can always have lenticular myopia because the rays are unable to get focused on the fovea. They'll get focused ahead of it. And it may result in a pupillary block or shallowing of the AC due to its increased anterior-posterior diameter and blocking the angles. So microspherophakia is characterized by increase in this anterior-posterior diameter and decrease in this equatorial chamber, because of which we are able to see the entire equatorial margin in full mydriasis. So beginning with the case, there was a 24-year-old male who presented for just routine examination, and on examination of visual acuity, he was found to be myopic. So before proceeding further into examination, we have the picture in mind that this is a myopic patient. Anterior segment signs, we expect a deeper AC. However, when we started examining, there was a shallow AC. So why can a myopic patient have a shallow AC? And whether should we dilate this patient or not? We ordered for an A scan with lens thickness, and A scan was also normal. Now, in a myopic patient, we would expect a longer action length. But this myopic patient having a shallow AC, not a deeper one, and with a normal axial length, it all points towards the lenticular myopia. And also, there is something about the lens thickness which is abnormal. That is, it is increased. So the anterior-posterior diameter is increased. So this all points towards microspherophakia, and hence we dilated the patient. This is the anterior chamber depth in undilated state. Post dilatation, what we see is there is equatorial margin which is visible in full mydriasis with intact zonules. And after dilatation, the fundus was normal. So the clinical, the hallmark triad of microspherophakia is there is lenticular myopia, there is shallow AC, and angle closure glaucoma. So regarding discussion of this case, I request the glaucoma panel for their inputs, whether this patient should be observed or prophylactic peripheral iridotomy is to be considered, or is there a medical management that should be done, and how frequently the patient should be called for the follow-ups.
Thank you for the question. As seen in the examination, the intraocular pressure of the patient on examination looks normal, that is 20 and 80 millimeters of mercury. And on gonioscopy, the angles were, can we go back to this slide? The angles were open. Despite being a shallow AC, the angles were open, IOP was normal. So we can safely proceed with dilatation. As well as after dilatation, we see that the lens is in position. There is no phacodonosis or subluxation as such. And the fundus is also normal on examination. And the patient is comfortable. There are no acute signs of any angle closure or pupillary block. So we can safely observe the patient's 6-monthly follow-up can be advised. As of now, no need of any medical or any intervention. So we can ask for the patient for a 6-monthly follow-up to check for any further signs of angle closure, because the lens keeps on increasing. So in the future, there can be a pupillary block.
So another case, it was a 27-year-old female who came for a follow-up examination.
You're saying it will be safe to send the patient home after the dilatation?
It actually depends on the zonular stability, sir. If we feel that after examination the zonules are safe and they are stable enough, we can send the patient to dilated state. But if we are having even a small benefit of doubt, we can wait for the patient to have this pupil constructed to the normal size, observe him until the pupil constructs back to the normal size, and then send him back home to avoid the inadvertent complication of anterior subluxation of lens.
First thing would be to be safer to for complete or at least partial till the iris pupil area crosses the equator and come. The second thing is now in the PAC, when you have, there are sometimes you indent, and though there is only 2 angles that are open, okay, less than 2 angles, you will go ahead directly and do a PA. But if there are 2 angles open, 2 angles are not opening, only 2 angles are opening. But still, you are saying that in future, as the lens diameter increases, it is going to be progressively narrowing, right? So, in the same concept of a prophylactic, so what is the role of a prophylactic PA? Because you know it will increase the anteroposterior diameter. That's one. Number two, how sure are you of whether this patient is, though they will nod and say things that they will come for follow-up. How often have you seen for a no complaints, regular follow-up? There are very few patients who come. So what is your role, or what would you say? Is there any harm in doing the prophylactic PA straight away?
In the literature mentioned in Sheets book, sir, it has mentioned that prophylactic PI can be done in these patients. But as the patient was a young patient, he was educated, he's working, and he was compliant, and he was like, when we counseled him regarding the future complications that might occur, he was willing for a follow-up regularly. So we safely advised him for a regular follow-up. It depends on the patient compliance and how.
Same patient for a regular guy. If you go ahead and do a test, it's a very
Yes, sir. Of course, a prophylactic PI would be a safer way to approach to that patient in order to avoid further pupillary block.
Moving to second case, it was a 27-year-old female who came for follow-up visit, and the yard peripheral iridotomy was done 2 years back. She was also a high myopic patient. The PI was found to be patent, and the pressures were controlled. The patency of the PI can be made out, and also the translumination effect. So the indications of PI, as have already been discussed, that there are some patients in which prophylactic PI helps control their pressures and maintain the vision. However, they need to be called for frequent follow-ups. As the age increases, the anterior posterior diameter further increase. So they need to be closely observed. Another case, which was 15-year-old female, and she had a history of yard peripheral iridotomy 3 years back.
your first and second cases. The management. Though the IUP was normal, the disc was normal, right? What feels done? HFA or an OCT, was it done? OCT of the optic nerve or fields, were they done as per the record?
No, sir.
No.
The pressures were normal, the cup disc ratio was fine, and the angles were open.
So there was, you would say there is no indication of to evaluate fields.
We should have done to rule out pre-perimetric.
Is one. The other is, I would say that when you know that there is a very high likelihood in future of development of glaucoma, to have a baseline evaluation. How often have you seen that after you have diagnosed glaucoma, where the patient is unfamiliar with the technology of the act of doing fields? It takes about 2-3 fields for you to get past that learning curve, and then give you an accurate fields. Now he has no disease, but would you say that this is the ideal time for you to get a baseline fields and for training him for future tests?
Having a baseline fields and the OCT of the this would be a better for further comparisons at every visit.
The change is
Yes.
more important.
So in the child, actually these patients were highly microerrors, and the chances of one is the age-related matching of the data set. Less than 18 years, we won't have much data. So individually, we should take the patient and we should see. The second thing is, yes, change.
You won't have
Yes,
formative data.
yes,
In that case, the change is even more important.
yes, even more important, but the thing is that high refractory errors, it won't give us the correct values.
The high refractive error is not only change, it is there for life for this patient. The same
So
patient.
this patient, for example, have a use a 10% reduction in the RF. That means there is the same patient, a different technique. So baseline.
Yes, sir, but they're not, even the same patient, the values are like not reliable, sir, that's what I mean. Because of the high refractory error, the machine is,
If you want to say reliability, refractive comparison to a normative data, fields may not be useful.
yes,
Okay,
yes,
one age, one refractive error,
Yes.
effects it causes.
But I am not looking at a normative data or I'm looking at a baseline data for me to compare future changes.
Yes, sir.
So however skewed this data is, that
That's
skew will remain for this patient.
Yes.
So when from the skew it changes to some other skew, that is more important to me for the diagnosis. Possible diagnosis.
So the third case, it was a 15-year-old female, and she had a history of young peripheral iridotomy 3 years back, and she was using Dorzox T. It was done outside. This was her first presentation with us. Her vision was not improving to more than 636 and 624 in right and left eye respectively. And on examination, the AC was shallow. The AC was shallow. And there was a PI which was patent. So in spite of patent PI, the AC was shallow. Like as we discussed, it's not, after doing a PI, we still need to closely observe the patient. And on application tonometry, the pressures were high, as high as 42 and 40. Gonioscopy was performed and the angles were closed. The fundus was normal and the cup-disc ratio was fairly normal. So after dilatation, we saw the equatorial margin after full mydriasis, indicating microspherophakia with lenticular myopia. So then I would like to request glaucoma panel for their inputs, whether trabeculectomy should be done first or lens extraction to address the high IOP in such patients.
It is always the microspherophakic lens that is the culprit behind the iris, behind the angle closure or pupillary block, raising the pressures. So first we'll go for lensectomy. We'll check for the pressures, followed by a secondary angle implantation, either iris or SFI, depending upon the further requirement for trab or GDD. And then, depending upon the progression of the disease, then we can go for a filtration surgery. So first, lensectomy would be a preferable choice of treatment. Next step.
As lens is the main cause of increased IOP. So lens extraction was performed. And after 1 month post-operative, we can.
Sorry to interrupt, but you had somebody is watching you live and asking questions. Okay, if I just read out the question, you can answer. What about the peripheral retina in these high myopes? Retina person can answer.
The myopia in microspherophakia is actually lenticular myopia, but considering that a lot of them have syndromic associations, like you can even have Marfan's. So all of these cases do have peripheral retinal degenerations. They have abnormal vitreoretinal adherence also. So there needs to be a thorough fundus evaluation, but making sure that the patient is dilated in supine position, fundus examination is done in supine position, and the pupil is allowed to constrict in the supine position. And also, if at all the patient undergoes a cataract surgery, so then a cataract surgery is known to cause an earlier induction of PVD. So there is an increased lifelong risk of the patient having retinal detachment. And if the patient has an anterior subluxation of the lens with vitreous prolapse, so there is going to be some amount of vitreoretinal traction in the periphery. So these patients need to be screened meticulously to rule out any retinal breaks, and thus the treatment needs to be taken. And there should be regular screening if they've undergone a early cataract surgery or a lens extraction.
So after cataract extraction in this patient, the vision significantly improved up till 6.6 and the IOP became under control with a formed AC. So most of the times, glaucoma filtration surgery or glaucoma drainage devices they are not required if we diagnose the case correctly, and we can come to a conclusion that lens is the main cause of culprit of angle closure in these cases.
There was a patent before.
Before also, sir. In first presentation also there was a patent PI, and still there was this shallow AC.
Go back to your slide. The same before slide. What is the vision slide?
The post-op vision.
Any of the residents? Why is the pinhole vision 636, 624? The post-op vision is 6966. Pre-op PCVA is 636 and 624. It's a clear lens, remember, there is no cataract. Can anybody explain how there is a gain in BCVA when you remove a clear lens?
We lag in the accommodation in this vision, so there is no improvement in the whole vision.
Cases were distributed, cases were told. No reading up. The very high myopia.
Very high myopia, there is, magnification with the glasses, right? So that is actually itself is a skewed visual eye, because there is magnification. So when you remove the magnification, there is magnification reverse, and that is why you land up with a gain in vision. So this you will encounter in refractive surgery also. Anybody more than -6 or -8 when you do LASIK or when you do ICL. The pre-op PCBAs are only 6.9 or sometimes 6.12, but post-op they go to 6.6. Though we don't assure them, but that's a pleasant surprise because of the loss of magnification. And the same converse will used to happen in the old days, where people with AFAK glasses, because of magnification, they would actually be reading more. Right. So even though that magnification would mask some of the subclinical CME that they would have. The patient would have say 612, and then you implant a secondary IOL. The magnification is lost. So from 612 it drops to 618. Okay. That you have to keep in mind, refractive error with respect to this image size on the retina.
I have a question. Same patient, go back to the factors. If it was 6.9, the best corrected visual acuity was 6.9, and the myopia was around 9 or 10, but the pressures are still high. Do you still want to go ahead with lensectomy, or you are thinking like the vision is 6.9, 6.6, you want to wait, or step up the medical management?
Ma'am, according to the literature, the first treatment of choice is lensectomy. There is 60% chances of failure with peripheral iridotomies and even anti-glaucoma medications. So ultimately, the answer is clear lens extraction. Even if the vision is fine today, but the pressures are high, it is better to go for lensectomy, according to me. Maybe the panel can add a little more.
Always it's the lens that is the culprit behind the raise of the intraocular pressure. This irrespective of the vision, if the pressures are raised, we can go ahead with the lensectomy, and later we can decide on adding agents or further trabeculectomy surgeries depending upon the amount of IOP that comes down.
We always tend to look at a normal eye, and then you are thinking of your normal eye managements. This is not a normal eye. So this is an abnormal eye with a normal lens that is sitting there. So that is the cause for all your problems. If you think like POAG or a PACG, you want to include trabecular, or all those are perfectly normal in this eye. Okay, a normal eye with a normal drainage is now having pressure. Whereas in the POAG, there is some sclerosis, there is some outflow obstruction, be it clinical, but that is the reason why you are looking at drugs. But here it's a perfectly young guy with good trabecular meshwork and a normal, there is no hypersecretion of the aqueous. There is a normal secretion, but there is a normal outflow. And yet the lens is somehow causing it. So the root cause is the lens.
In Rao et al. Found that lensectomy is effective up till 69 to 70% of the spherophakics, and the other 7 to 7.7% who further need glaucoma surgery, they might have some preoperative risk factors like poor glaucoma control or a high cup disc ratio. So with these three cases, we can sum it up like the first case, observation was done as the pressures were normal, the angles were open, and it looked like a with strong zonular integrity as there was no donuses and it put a well-centered lens in the full metastasis. However, PI was done when the pressures were high, even when the vision was normal. And lensectomy, when there was a question on zonular instability and there was a clear-cut phacodonosis or there was a decentered lens in the full mydriasis that makes us question on the zonular instability, then lensectomy can be done. And despite lensectomy, if the pressures are not controlled, ultimately glaucoma filtration surgeries or drainage devices need to be considered. Now, till here, most of 40 to 50% of the cases have the sight-threatening complication of glaucoma. That is the main cause of the diminution of vision. Microspherophakia can occur in isolation or with syndromes. One such example is this case, after systemic evaluation, was found to have short stature, brachycephaly, brachydactyly, glaucoma, and joint stiffness, and was diagnosed as Weil-Marchesani syndrome. The gene implicated in Weil-Marchesani is ADAMTS10 and FBN1, which is responsible for the integrity of the zonules and their development. Any gene mutation in FBN1 or ADAMTS10 can manifest as zonular instability in the eyes as well as in the joints, in the cartilage, and can give rise to syndromes like Weil-Marchesani syndrome or homocystinuria or Marfan syndrome, in which the chances of subluxation of lens should be considered. Coming to case number 5, it was a 7-year-old female who came for follow-up examination. Her vision has significantly dropped and the pressures were normal. On examination, the lens was clearly sitting in the AC. As we can see that iris is way behind the equatorial margin, and this was an anteriorly subluxated lens for which lensectomy was done. And the patient was found to have high levels of homocystinuria. The ASOCT showing the lens which has subluxated anteriorly. So, if pediatric ophthalmology panel can add when should we consider lensectomy or IOL surgery, and what are the IOL options that are available if the patient is having microspherophakia?
As this case is considered, it is clearly a surgical emergency because it is already anteriorly distributed into the anterior chamber. Luckily, the lens is not in contact with the endothelium and there is no corneal decompensation as such, and the IOP is also normal. But we don't want the lens to cause corneal decompensation, so it is a surgical emergency. We can straight away go to the surgery and do the lensectomy procedure. But as for the IOL of choice in this case, there was significant iris atrophy because this child had multiple episodes of such conditions in the previous years. The mother said the history of frequent episodes of headaches and decrease in the vision of such episodes. So because of that, there is iris atrophy. So we cannot go for iris flaw lens or iris enclavation. And because it is a child and safety of the scleral fixated IOL, we cannot assess at this point in time. So it is better to go ahead with the lensectomy as first sitting as an emergency management, and then later on decide the scleral fixated or the iris flaw later on when the time is, after the frequent follow-ups. As for the vision, we can try for the refractive correction and see how the vision is improving. If it is improving better, and with the amblyopia management and the refractive correction, the patient can be managed till we can go for the secondary IOL implantation.
And ma'am, what does the zonular integrity has the bearing on choosing the IOL or capsular tensional ring?
Zonular integrity, first of all, pediatric patients, it is very difficult for the examination itself. Depending on the age of the patient, if the patient is cooperative, we can go for a dilatation in supine position and then examine the zonules, the structure of the zonules and the integrity of the zonules. If there is any deposits and if there is any phacodonosis. And if there is any subluxation, how much amount of the subluxation is there? But if the patient is not cooperative and it is a way younger infant, we should go for examination under anesthesia. So that we can assess the zonular integrity bearing on the angle, structures, intraocular pressures, and then later decide on the management further. For IOL choices in microspherophakia, there are several choices, but every choice has its own disadvantages and advantages. Right now, iris claw lens, scleral fixated IOLs, iris enclavated IOLs are the choice of IOLs in microspherophakia.
There is in the bag in the lens applicable somewhere.
There is new additional bag in the lens where there is a groove in the surrounding and capsule can be fixated enclaved into the groove. That can be opted for the pediatric cases.
So that is the customized lens for microspherophakia cases, in which the viscoelastic is injected over the anterior capsule and behind the posterior capsule, but not in the back, so that the anterior and posterior capsules are opposed. And the capsule which are opposed can be fit in this groove that is present in this lens. So we all have heard lens in the bag for a very long time. This is something which is bag in the lens. The lens is taking support from the bag that is already present, and that is supported by the zonules.
I only heard it. Pediatricians do it, but I have not seen or heard that.
Because when enclaving, sometimes the units are operating. Yes, ma'am, that higher chances of complications of this inflammation is there, and the patients present with that optic capture later, and the entire lens is within the iris. So when to dilate and when to constrict, as has already been discussed in case 1, that if the angles are open, we can go ahead for dilatation. But if the angles are closed and there is a sign of microspherophakia in A-scan through the axial length or the lens thickness, and we are suspecting microspherophakia, we can dilate. And about sending the patient back, if the zonular integrity is good and there is no donuses, there is no subluxation, it is a well-centered lens, that itself indicates that although zonules are weak, but they are capable of holding the lens in the center, and the patient can be sent back. However, if there is donuses or there is slight decentration, then the patient has to be constricted under observation in supine position and only then sent back. So regarding management of microspherophakia, myopia has to be addressed to prevent amblyopia, intermittent pupillary block with peripheral iridotomy, as was clear in first 2 cases, angle closure glaucoma, and lens subluxation. We have discussed anterior lens subluxation. We would like to know what if the lens dislocates into posteriorly, and what is the role of pars plana lensectomy in that? Shivranjani ma'am, if you can answer that.
So even before planning for a anterior approach for lens extraction, one must examine the patient in the supine position, as many a times one may miss that the lens is actually more posteriorly dislocated in this sitting position. And for posteriorly dislocated lenses, we would go for a pars plana lensectomy, and there should be a thorough screening of the periphery intraoperatively, and necessary treatment should be given to the areas if there are any retinal degenerations. And there has to be extra care if there is a PBD induction being performed intraoperatively, as these patients will have a very dense vitreoretinal adhesions, and patients may end up in complications. And if you're planning for a pediatric patient, so considering in mind that multiple times general anesthesia, so think of visual rehabilitation, and also try a plan in case the patient is going to require a glaucoma, a trabeculectomy. So as to plan about your visual rehabilitation so that the child doesn't end up in amblyopia.
It's not no longer practiced routinely now. But in the olden, in not very old also, couple of decade or so before doing clear lens or before doing LASIK or ICL, there were some practitioners or some schools of thought where a prophylactic peripheral 360 barrage was done. Considering, as you said, the higher risk factors because of the abnormal vitreoretinal interaction adhesions that are present, and that it is, if something should happen, it's a pediatric again GA. Is there any role now of a 360-degree prophylactic barrage without lesions?
Sir, laser is also like a double-edged sword. So I don't think, and there is literature also does not say that patient should undergo prophylactic 360-degree barrage, because you can have laser-induced breaks, and so I would not advocate for.
For literature to say that something is recommended, that event should be occurring quite frequently or at least reported. Most of these would be at the level of case series. You cannot do an RCT. Okay, the numbers are not, don't support you. So it is definitely your clinical experience and your way of in your hands how does things work. So is there a difference or?
Yeah, the first thing is a good clinical examination. So as a clinician, if I feel that there are areas of thinning or a predisposing retraction or a fold, not say 360 for sure, but a limited barrage laser is what is recommended. The problem with 360-degree lasers is, one is the laser itself can cause a lot of issues, including the anti-segment ischemia. It may not happen at that time, but subsequently we see, because when we see that the laser which is done in ROP, which appears very tiny, at 2 or 3 years of age, the lasers are this big. The laser scars expand as they age. So considering that 360-degree barrage is almost seldom, which is being done now. Barring in few cases like in Marfan syndrome or in other connective tissue disorders, where we have vitreous wheel syndrome, where there is a 360-degree vitreous traction, which happens in that cases, posterior to the vitreous vitreoretinal traction, there we give rows of lasers, so that even if there is a detachment, the macula should be safe. But this is done in very, very few cases. Otherwise, yes, any suspicious areas, we can do a barrage safely around it, but not 360.
In cases of late retinal tears, as you asked, they have done prophylactic lasers for lesions such as white without pressure. So, and they found that I don't exactly recall literature, but when I have discussed with our colleagues, they have told that they used to do for white without pressure, which is not an indication as per literature, and they've had change retinal tears after laser. So that's why maybe she's also telling that literature according to is not there to do if there are no treatable lesions.
Thank you. I would like to invite Dr. Akanksha for her next case, clinical case presentation on ptosis.
Two questions. Yes.
I am online.
Okay, to the previous panel still, you can still answer. Is one of the questions online was, is a posterior lensectomy preferred or an anterior lensectomy preferred?
So there is always a debate for limbal approach and also the post-pars planar lensectomy and vitrectomy approach. Results were good with pars planar lensectomy with SF5L implantation, but there is always the risk of vitreous posterior vitreous detachment and future risk of retinal detachment more in these cases. So since we are operating pediatric cases, we don't want that follow-up period to be prolonged. So for these cases, limbal approach would be better, and most of the case series, all the studies which were conducted were done in the limbal approach only.
Good evening, everyone. Today I will be presenting a case.
So pars plana approach or limbal approach will depend on a couple of things. One is the intactness of the anterohyoid. If the anterohyoid is intact, the vitreous is not liquefied much, definitely anterior approach is superior. If the anterohyoid is already disintegrated and you see that there is a vitreous which is peeping through your zone, which are the lens, you have a phacodonosis and it dips a little inside, then the anterior approach is again okay if you are doing a good anterior vitrectomy without causing too much of traction. So here the instrumentation what you have, good anterior vitrectomy cutter and your experience in doing the anterior vitrectomy without leading to much vitreous traction is more important. So limbal approach is preferred one because in these patients the vitreous is not that liquefied in pediatric patients. So pars plana has to be a second choice. Barring in few cases where you have connected disorders, vitreous is already liquefied. In those cases, the vitreous is the lens is dipping a little into the anterior vitreous, then pars plana.
And in one paper, they have mentioned that examining the patient in supine and then bending the head backwards, if we see there is dislocation towards the back,
Exactly.
towards
That's
the
what
ear,
actually
that's an indication for pars plana.
So those things are to be considered.
It is developmental delay, why only journals are affected, why not other parts of the eye?
So other parts can also be affected. It is usually associated with developmental anomaly of the angle as well. We tend to believe that microspherophakia will cause angle closure, but in fact, in Shields, it's mentioned 25% of microspheria cases end up in open angle, owing to the developmental anomaly of the angle. So along with that, there is an angle anomaly also, and in some syndromes like Marfan syndrome, they say that the iris is thicker. The trabecular meshwork has an abnormally large spaces. So those things are also mentioned along with the developmental anomaly of the zones.
Good evening, everyone. Today I'll be presenting a case on ptosis. So Sarath Babu Bonigola, 40-year male, presented to us, a shopkeeper by occupation and resident of Chinnapandraka village, with chief complaints of drooping of right eye upper lid since 2 months. Patient was apparently asymptomatic 2 months back when he noticed drooping of right eye upper lid. The drooping of lid was less in morning and was increasing towards the evening. There was no associated history of weakness in the limbs. There is no associated history of difficulty in swallowing food or slurring of speech or difficulty in breathing. There is no history of frequent rubbing of eyes, no history of contact lens usage or any history of ocular trauma, and there is no history of any eye surgeries. Also, there is no history of diplopia or deviation of eye, and there is no similar complaints in the family. There is no history of any systemic illness, as well as there are no history of any allergies. The patient has mixed diet, the bowel and bladder habits are regular, sleep is adequate, and there is no history of tobacco or alcohol consumption habits. General physical examination showed that patient is moderately built and nourished. Patient is conscious, cooperative, and oriented to time, place, and person. Temperature was 98 degrees Fahrenheit. The pulse was 78 per minute. Respiratory rate was 17 per minute. And the blood pressure was 124/90. There was no pallor, icterus, clubbing, or cyanosis. There is no lymphadenopathy, no edema, and the systemic examination was also within normal limits. On ocular examination, the head posture was normal. The facial symmetry was asymmetric. The right eye had ptosis, and the ocular posture was orthophoric. Extraocular movements were full and free in all cases. Visual acuity in both eyes was 6.6, and in near vision also it was N6. On anterior segment examination, I will like to start with right eye. The eyelids had ptosis in right eye. Regurgitation on pressure on lacrimal sac area was negative in right eye. Conjunctiva was muddy in appearance. Cornea was clear. Anterior chamber was normal in depth, Von Herix grade 4. And iris was normal in color and pattern. So ptosis evaluation was done. In right eye, the palpebral fissure height in primary gaze was 8 mm. In up gaze, it was 10 mm. And in down gaze, it was 2 mm. The marginal reflex distance 1 was +1, and the marginal reflex distance 2 was 7 mm, and MRD 3 was 2 mm. There was no lid lag, and LPS function was 13 mm. Lid crease was present in right eye. The marginal crease distance was 7 mm. Bell's phenomenon was fair. The jaw winking phenomenon was absent, and the eye spec test was positive. So there was improvement of marginal reflex distance 1 from 1 mm to 4 mm after eye spec test. The fatigability test was positive. Extraocular movements were full and free in all cases. There was no leg ophthalmos, and there was no frontalis overaction. The anterior segment examination of left eye, the eyelids were normal. There was no regurgitation on pressure of lacrimal sac area. Conjunctiva was muddy in appearance. Cornea was clear. The anterior chamber had normal depth with Von Herix grade 4. The iris was normal color in pattern. The palpebral fissure height in primary gaze was 11 mm. In up gaze, it was 14 mm. And in down gaze, it was 4 mm. MRD1 was +4. MRD2 was 7 mm. And MRD3 was 5 mm. There was no lid lag, and LPS function was 14. Lid crease was present. The marginal crease distance was 7 mm. Bell's phenomenon was fair. The jaw winking phenomenon was absent. Eye spec test was negative, and as well as the fatigability test was negative. The extraocular movements were full and free in all cases, with no leg ophthalmos and no frontalis overaction. The corneal sensations were present in both eyes. Schirmer's test 1 and 2 were normal. On further pupillary examination, the pupil was round, reactive, and regular. The lens was clear, and intraocular pressure was around 40 mm in right eye and 12 in left. Anterior vitreous was clear in both eyes. So this was the patient pre-eye spec and post-eye spec. As we can see, there is improvement in the marginal reflex distance 1. There is improvement in the palpebral fissure height. The posterior segment examination done in 90 diopter lens and dilated pupils. The red glow was present in both eyes. Media was clear. The disc was 0.3, healthy notoretinal rim. Peripapillary area was normal. The blood vessel. So my diagnosis is right eye moderate myogenic ptosis with most probable etiology of ocular or myasthenia gravis, and left eye is within normal limits. For this patient, further we investigated, and the patient turned out to be neostigmine test positive, as well as the acetylcholine receptor antibody titers were positive, and the CT chest showed lobulated isodense lesion in anterior mediastinum, suggestive of thymoma. So I would like to ask the question to the panelists. So what is the further treatment we can do in this case?
Usually we go for medical management. Initially, the first line of drug is anti-acetylcholinesterase inhibitors. And if the ptosis is accompanied by diplopia, then we add steroids to it. And then later, if this in CD chest, if we see any thymic hyperplasia, we can go for thymectomy. If there are any chance of spreading, then it is converting to general myasthenia.
What anticholinesterase inhibitors you can recommend?
It's pyridostigmine bromide, 1 mg per kg DID.
What would be the indications of hyperactivity?
If it is progressive and it is converting into general myasthenia, and if the duration is like more than 2 years, then we go for thymectin. If it is not getting subsided through medical management.
If medical management is not sufficient, we can go with thymectomy, but thymectomy is an adjunctive treatment to it. It is not the whole and soul treatment. As well as apart from this, thymectomy should be done up to 55 years of age, because after that there will be involution of thymus. And the second one, yes, we can do in this case. As well as the second indication is, regardless of the age, if the patient is having thymoma, we need to remove the thymoma. So because there is, it is a locally invasive tumor, that's why. So thymectomy should be done. Yes,
The age of this patient,
40 years.
but in your diagnosis, you didn't check for presbyopia.
So I checked, it was N16. Yes,
But don't miss that.
yes. I
You
can.
have other things, you may even have a proptosis. The age is above 40, presbyopia should be added to diagnosis.
Okay.
Prognostic factors where ocular myasthenia converts to generalized myasthenia.
Presence of anti-cholinesterase receptor antibodies is an important prognostic factor. It is positive in almost 90% of the cases in systemic myasthenia gravis, whereas in 50% of the cases of ocular myasthenia are positive to that. And also presence of thymoma also is an indicator for the development of systemic myasthenia.
Nice presentation. I just want to ask you, what is the diagnosed as ocular myasthenia? So what will you tell the patient? What will the patient, the moment the patient hears myasthenia, they're thinking that they can die at some time, right? Because that's what people tell. That's what Google tells. What will you tell the patient about ocular myasthenia?
So if it is only ocular myasthenia, then the symptoms will be only up to the eye. So and as well as if it is systemic also, the respiratory muscles are the last to get involved. So fatality is less in these cases, but in conditions where myasthenic crisis, we will alert the patient about myasthenic crisis when the respiratory.
Let's get this clear. This patient has ocular myasthenia or systemic myasthenia?
For at present, ocular myasthenia.
No, but he's got everything systemic. He's got a thymoma, he's got more titers positive, everything's there. Why are you saying only ocular? Why not systemic? It's
So-
only 2 months. Give it some more time.
Yes, sir.
I'm just asking a question. I don't know.
So they have said that even in ocular myasthenia, thymoma or thymic enlargement can be there because it is a source of antigens and antibodies by helper T cell formation. So thymomas doesn't indicate that it is systemically involved. So at present it is ocular, but definitely we'll have to follow up the patient and see if it gets converted into generalized myasthenia.
So you want to remove the thymoma or don't want to remove it?
I want to remove them.
So why do you want to remove it? The patient doesn't have systemic problems.
So because it is a locally invasive tumor and therefore it can cause other abnormalities at that site, that's why.
So you want to do a thymectomy for systemic local problems rather than future myasthenia. I understand. Now I'm confused. See, as a patient, I'm thinking, I've come with a problem since 2 months, and you've done a test, and then you said you have a tumor in the neck. And then you say that this is the reason why your eye is behaving like this, and this should be removed. But whether I remove it or not, you're still going to get systemic myasthenia. And I'm confused, do I remove it or not? Because I'm not having any problem in the neck now.
The lymphoid tissue is the site for the development of the anti-receptor antibodies. So if we remove the lymphoid tissue, there is a chance of reduction of the generalized myasthenia.
So it will not completely void out the disease, but it will definitely decrease the progression.
Right, see, we don't know about the progression. See, what you're doing is you're decreasing the load that the body is going to be getting exposed. And you hope that this decrease in the load is going to control with your medications. Right, that is what you're going to do. It may or may not work out. That's why the studies say that if you do a thymectomy, you can still have systemic myasthenia. That's the reason why you need to give it. So what you're doing is, you know that is the one that's presenting the antigens. You want to remove that part. It may or may not happen. That's why when you have a tumor elsewhere, you want to remove it, because that is the one that's going to cause future problems. It can cause metastasis. The more you keep a tumor, the more malignancy, the more the chance of metastasis. Even though locally the PET scan may show nothing at all. You don't want to keep it. You want to remove it because the load is always going to be there. The primary presenting site is always a load bearing site. And the load is always going to be shed across the body. So you want to remove it. Right? Now, I have another question, doctor. Clinically, what is the things that I need to keep in mind apart from myasthenia, from the clinical findings? But because you did this test, you had myasthenia in your mind. But any other differential diagnosis I need to keep in mind when I'm seeing in the OP?
So at this age, other causes of myogenic ptosis can be myotonic dystrophy, where also the patient will complain of ptosis and ophthalmoplegia.
Chronic progressive external ophthalmoplegia.
CPO is usually used bilateral. Bilateral CPO, not possible. CPO by definition is bilateral. See, you said the patient has multiconjunctival.
Yes.
Can that be related together to cause ptosis? Can have mechanical ptosis. You had papillae or giant papillae in the conjunctiva, right? That's very common. And it's not just in young children, also in adults. So when you have long-standing allergic conjunctivitis, you have a multiconjunctival. The conjunctiva itself becomes heavy. You can have. There's another test that maybe you could have heard is the phenylephrine test. The phenylephrine drops that you can do, and you see the response on the doses. So ideally, you're supposed to put a 10% phenylephrine drop and see the effect on the doses. So it will give a transient improvement on the doses, irrespective of whether it's a thymoma or myasthenia or non-myasthenia. Right? So that also tells you the amount of elevation when you're planning other surgeries, in case you want to plan a surgery for non-myasthenic patients. So that also it helps you to show the tone and the thing. So in a myasthenia patient, when you put phenylephrine drops, there will be a lift, but it will be equal in both the eyes. It will not be as dramatic as what you showed in the eyes practice. And regarding the new screening test, I think you did it right.
Yes, like we had referred it to the neurologist. Yes.
So and the ice pack test. So for the interest of everyone, can you just tell how is the ice pack test done?
So we will first measure the palpebral fissure height and marginal reflex distance 1 before starting the ice pack test. Then we will apply the ice pack over the lid for 2 minutes. And after removing the ice pack, we will again measure the palpebral fissure height. And if there is improvement of more than 2 mm, it is more significant and diagnostic for myasthenia gravis.
Right, that's fine. But why you so dogmatic for 2 minutes? Any ideas?
2 minutes. Why?
The laxity. If you keep it for a longer time, it's going to freeze the muscle and the fat around it.
No, the body won't get frozen. The muscle won't get frozen. Yeah? No. You're not deactivating any enzymes which is like cold compress. So how does this cold compress work actually? What is the rationale? What is the physiology of a cold compress?
So it increases the acetylcholine at the junction and makes the receptors again active. Whatever are inactive are blocked, get activated, and that's why there is improvement in the doses.
Right. So the question always arises is how do you keep it? See, the right answer is not there. 2 minutes can be intolerant for many patients. If you try keeping an ice cap on your lids, I'm sure you'll not be keeping it for more than 30 seconds. It will all cause pain. So 2 minutes is too much of an overkill. The idea of giving a cold pack is that you want to bring down the temperature, right? From the body temperature, you want to cool it down. So you give it intermittently. But that removal time should be too much that the body warms it up again. It should be still cool. Because if you keep it constantly for some time, it will be very painful. Right? So you put it, take it out, so give about 10 seconds, take it out for maybe 1 or 2 seconds, put it back again. So you want it to be much cooler than your body temperature. The moment that happens, you can see the effects. And as the temperature rises, you can find that the will start slowly falling down. Right? If you're sitting in an AC environment, your room is air conditioned, you're having an 18 degrees temperature, it will stay for longer. If you're seeing it in the outside your clinic with the family members, all patients sitting around, the AC is not working, it's instantaneous. The moment you take out, the body warms it up. So you should keep all these small factors when doing ice pack test. So ice pack test is an extremely sensitive and specific test for myasthenia, ocular myasthenia. And because it is safe, it's much preferred over neostigmine test. Neostigmine test, you cannot do it without an ICU setup. Because there are patients who have died in the process of doing a neostigmine test. There's been no report yet of a patient dying because of an ice pack test. Right? As of now. So it's much safer. You can do it locally without any problems. Okay. Another condition that you can have with one eye falling down in a young patient is aponeurotic ptosis. Okay. But of course, the only clue that it's not an aponeurotic is your decreased height is equal in both eyes. That's the only clue. Otherwise, you can still have aponeurosis in one eye at a young age. It doesn't have to happen only in old age. Right? So we've seen aponeurosis in younger patients, 15 years, 16 years old patients. Of course, the imaging diagnosis, you've got all it is positive, so it is myasthenia.
Myasthenia patient not only present in ptosis, they can also be severe oblique palsy. They can also present in ophthalmophakia. And every ptosis is residents usually jump with corneal palsy, but it is also we have to evaluate the myasthenia. And myasthenia not only present, it's not like fixed present only with ptosis. It also presents with superior oblique palsy in many cases.
Okay. So we close it now that the YouTube shutdown unit, sir will just speak. So if the superior oblique is involved, so the patient would complain of intermittent diplopia. Would that be the listen? We'll go offline.